Hello, my name is David Kooby. I'm a surgical oncologist with Emory University and the Winship Cancer Institute in Atlanta, Georgia. I focus on gastrointestinal malignancies and primarily on foregut malignancies, which would include malignant tumors of the benign and malignant tumors of the liver, stomach, pancreas, and intestines. A question comes up about symptoms from various types of tumors in the pancreas, specifically neuroendocrine tumors. And the symptoms will vary based on the tumor type. In general, I think it's always good to have the discussion where we think about pancreas tumors in general. What percentage of them are going to be these neuroendocrine type tumors? And it's usually about 5 to 7%. So the majority are not of this variety. Now, within that 5 to 7% of pancreas tumors that are neuroendocrine tumors, only half or slightly less than half will actually produce symptoms based on elaborating a specific chemical or hormone that's going to spill into the bloodstream and have some downstream effects. So really, those are based on what the pancreas naturally produces as an endocrine organ. And the key ones are insulin and gastrin and glucagon. And there are a couple others such as somatostatin and vasointestinal peptide. So the most dramatic probably is the insulinoma. So, both physicians and laypersons understand that the pancreas produces insulin, which helps keep our blood sugar in a good steady state so that our bodies function appropriately. And if you have a tumor that's elaborating a high level of insulin or producing a lot of insulin, well, then the blood sugar will drop inappropriately. And I have had many patients who have to wake themselves up in the middle of the night in order to take some form of sugar so that they don't go into severe hypoglycemia, which can be fatal. And this can come on, somebody can be normal in life and then all of a sudden have this happen and their blood sugar will drop inappropriately. It is life altering. They can't sleep through the night. They end up gaining weight because they're taking so much sugar in order to compensate for the excess insulin production. And those patients are quite miserable. As a matter of fact, the surgery, once these tumors, insulinomas, are identified, to remove the tumor is extremely gratifying as a surgical oncologist because the dramatic benefit the patient will have from removal of this tumor is life-altering in a good way for the patient and obviously for their family. Insulinomas are probably the most common, along with gastrinomas, of the functional neuroendocrine tumors of the pancreas that produce this type of hormone such as this. They're thought to mostly be benign. And there is something called a 10% rule where these particular tumors are thought to be malignant 10% of the time and have some other features such as that. However, I think the reason they probably are thought to be more benign is because they're so symptomatic at a small size that we identify them and remove them before they have a chance to metastasize. Other tumors that cause less dramatic effects, such as a gastrinoma, that's the other one we should spend a little time on, will elaborate the hormone gastrin. And at very high levels, it is associated with peptic ulcer formation or atypical ulcer formation, where they'll develop ulcers throughout the body of the stomach and in the duodenum. Patients will have severe diarrhea as a result of the production of excess gastrin, and these patients can be quite miserable. Oftentimes, the way we manage it initially is by putting people on a proton pump inhibitor to shut down the excess gastrin, the excess acid that comes as a result of the gastrin production. But ultimately, if you get to the source of it, it's finding the tumor and removing the tumor or tumors that are associated with this excess gastrin production that will ultimately help the patient. A lot of times with gastrinoma, though, we're finding metastatic disease, such as enlarged lymph nodes. And there's a well-known syndrome, Zollinger-Ellison syndrome, which is associated with hypergastrinemia and these tumors, but oftentimes they are actually not in the pancreas, but can be found as small tumors in the duodenum itself. But since some of them are found in the pancreas or peripancreatic, they're included in this discussion about pancreatic neuroendocrine tumors. There is a condition called multiple endocrine neoplasia, which is characterized by tumors in various organs, of course, and one of which is the pancreatic neuroendocrine tumor. And so anytime we find a pancreatic neuroendocrine tumor, we have to work the patient up to make sure they don't have multiple endocrine neoplasia type 1 or MEN1 to make sure we're not missing other tumor types. As far as some of the less common variants, there's glucagonoma. Again, glucagon is sort of the opposite of insulin. It's going to actually raise the blood sugar. And so it's a very uncommon variant. Another one is a somatostatinoma. And then I mentioned the vasointestinal peptide, or VIPoma. It's associated with something called Werner-Morrison syndrome. And these patients will have severe watery diarrhea with low potassium and the absence of chloride production. And many of these will be managed medically with somatostatin analogs. If the tumor can be identified and removed, we can see improvement in these symptoms. Ultimately, these last few that I mentioned have a more malignant phenotype and oftentimes will present with metastatic disease. And then finally, there are rare functional tumors that may produce an array of different unusual symptoms. I've had patients tell me that they've even had some degree of erectile dysfunction that has resolved after these tumors have been removed, and we don't oftentimes get to the root of what the tumor was producing that allowed their symptoms to resolve after the tumor is removed. The other interesting component is when the symptoms resolve and the tumor is removed, return of symptoms could herald the return of the tumor. So it's a valuable thing to discuss with your patients that if any of the old symptoms, such as diarrhea or low blood sugar, pop up again, that they should seek medical help, even if it's in between the period of time that we do our scheduled surveillance, to let us know that, hey, there's a suggestion or a clue that a tumor may have returned.